Hello, this is Sanjay Ratnavel. I'm the president of OESIS, and I'm delighted to bring you a presentation today with a new partner of ours, Centogene. I'm joined today by Ellen Kargis, who is the Senior VP Pharma and Regulatory Compliance, and Dan Walsh in New England, who is in charge of sales. Today we'll be talking about a partnership that brings you real-time PCR tests for screening students and employees at schools. So this is a partnership that we have been working on now for close to 6 weeks. And I'm going to share a presentation here in a minute, and we will go through that presentation, and then we will take some questions at the end. Please feel free to submit your questions in the chat thread, and we will see whether we can answer as many of them as possible. Welcome, Ellen, and welcome, Dan. I'm just going to get to the presentation here. And let me start by giving you a little bit of a background. Even though my name is Sanjay, and you can tell from my complexion that I probably come from the Asian subcontinent, I am not a doctor. But we do have medical experts here who can give you much better advice. But when I started on this journey, an article in the New England Journal of Medicine is really what started me thinking that this is a very different situation than SARS-1, which is the last pandemic really that we were dealing with. And it relates to asymptomatic persons. And you can see if you read that article in the New England Journal of Medicine, that it's considered to be the real Achilles heel of current strategies to control COVID-19. And their recommendation is that asymptomatic people in nursing facilities and schools, to a large degree, are nursing facilities, should be tested. So the partnership was announced today, and if you go onto the Centogene website, you will see a press release that describes it. Centogene is a Nasdaq-listed company, and I'm going to turn it over to Ellen just to tell you a little bit about Centogene, and then we will walk through some of the major issues here. And there are a lot of issues that we've had to work our way through, touching everything from actually the privacy and data, to the sampling, to the timing, and the regulatory environment. So with that, Ellen, I'm going to pass that over to you.
Thank you. Hi, I'm Ellen, and I want to thank you for joining us today. Very exciting opportunities is here for both companies, and I'm very proud to talk about Centogene. Centogene is a company that just recently went public. We have laboratories globally and affiliations globally, and we do specialize in genetic and biochemical testing of rare diseases, and in this case, COVID being such a strong onset and being in a pandemic situation, we went into the COVID testing. We are a CLIA and a CAP accredited laboratory for high complexity genetic testing, and we developed and have our testing under EUA review to look at the early onset of COVIDs. So we are able to detect very low viral loads and at the very beginning, before symptoms develop. So we have experts from around the world that are a part of our company, as well as human geneticists, PhDs, medical doctors as well, that will be helping us along this adventure. So thank you very much for joining us today. When we talk about the testing landscape, the diagnostic that we're actually doing a oropharyngeal swab, which means the swab is taken from the mouth, which is a lot less invasive. We are looking at the genetic viral loads, very low viral loads at the very beginning. So somebody can be asymptomatic. That means they don't have a temperature, they don't have the aches and pains, they don't have flu-like symptoms. We're able to detect if they do have the virus. The normal screening patterns are you take your temperature every day as you come into work or go to the schools. This is a way of eliminating a lot of that, and you know the status of your child or yourself. Also, your staff members is very important to know if they've been exposed as well. So this is really an entire monitoring package.
Ellen, can I interrupt you for a second?
Sure.
I think it would be good for our schools because we're all pretty nascent in our understanding of all this, to talk about the difference between antibody tests and PCR tests and the various different other tests that exist.
Sure. When we talk about the various different tests that are being done, you have the PCR test, which is done for genetic tests, which means that's at the very early onset of the virus when you're first infected. When you talk about the antibody test, that means you've already been infected, you've gone through the 14-day quarantine, and you've developed antibodies to this virus. So the only time that you're able to see that is after you've gone through the period that you're infectious to everyone else that you have come in contact with. And then you're able to measure the antibodies that are in your bloodstream that develop because you were exposed to the virus. So in this case, that's not what you want going into the schools or going into the hospitals or into the workplace where you have large numbers of people having to work closely together, because that means they were infectious while they were there at work. And it's only after the infection has completed its life cycle that you're able to measure the antibodies in the blood. So it's really...
And these kinds of tests, Ellen, the PCR tests, they're not blood tests, right?
No.
There's the antibody test, blood test, and the PCR tests are amplifying the RNA to look at the genetic profile and correlate it with COVID-19, correct?
Yes, exactly. And these tests are also designed to capture patients that have symptoms and patients that do not have symptoms. And that is the group that we really are looking at, is as a preventative measure, is monitoring those patients that are asymptomatic that may be carriers of the virus. So I think that this is a very positive offering that OESIS is providing to the schools to ensure the safety of the children, of the workers, and of the families as the children go home.
Ellen, my father-in-law is a pathologist, and he runs a pathology lab at a hospital. I tried to get him to do this, and his response to me was, I can only process a small amount of tests on a PCR basis. Talk about how the tests themselves are processed and the issues regarding that, would you?
Sure. The methodology that we're using, we're able to do the oral pharyngeal swab, which is a swab that's inserted into the mouth that will scrape the skin cells, and it's just a scraping, so there's no pain attached to it, which has the DNA in it, where we extract the RNA from it. The RNA is then processed through what we call a PCR cycler, and those cycles are turned into a genetic code that we're able to look at to see if there's a variant within that COVID region. That tells us that the patient does have COVID. In some of the other methods, they're drawing blood. They're also doing PCR on it, but a lot of times you will also, if you don't get enough blood, if the blood is clotted, all of those things, you're going to have to go back and get stuck again. And again, it's only going to measure if you've already been infected and if you have antibodies in your blood. So the type of testing that we're doing, we would scrape it, we would extract the DNA or the RNA for the PCR cycling. We would run it through our analysis equipment or through the computer system that does the analysis, and we would get a response of either you're positive for COVID or you're negative for COVID. And you would get that report back. And so it's also a situation where we're able to produce 10 to 15,000 tests per day. So that way we have a very large volume, whereas in the local hospitals, in a lot of the local private laboratories, they're not able to generate those large numbers. So they're unable to meet the need of the testing here in the United States.
Got it. Great. Let's keep going. So talk a little bit about the regulatory environment, would you, and why there are so few tests and what the validations are for these tests, particularly the emergency use authorizations and the complexity lab authorizations and others.
Well, what happened is once COVID was called a pandemic, and we all know what happened in New York and the large number of patients that were infected, the FDA was not able to process the kits or the tests during the normal pathway. So they called it emergency use authorization, and they gave labs that were high complexity CLIA accredited labs the ability to validate these tests according to the CDC guidelines and the FDA requirements. They gave them the ability to validate the test under the CLIA regulations. The FDA would have oversight of looking at that validation, making sure that it was scientifically and medically sound, and then you were allowed to process those samples within your lab. During that time, you had to make an announcement to the FDA that you intended to do COVID testing, which is what Centogene did. We submitted all of the documentation, which means we talked about, we had to test a certain number of patients that were positive and negative. We had to show cross-reactivity data. We had to show the stability and the sensitivity and the robustness of the testing. We also had to compare it to other tests that have already previously been pre-approved by the FDA to show that our test was giving the same results as all the other tests, that we were comparable to everyone else. And we actually showed that our test is slightly more sensitive than the ones that are right now on the market and available to be used. So very proud of that.
So this is operating under an emergency use authorization.
Yes.
It's validated under the WHO principles.
It's validated under the FDA as well as the World Health Organization. We followed all of the CDC, World Health, and EUA FDA requirements. We're utilizing high throughput machines. The sampling is through the throat. So this is how we brought our test to the market.
And Ellen, since you mentioned the throat, that New England Journal of Medicine article talks about the fact that there is a lot more of the virus released from the pharyngeal throat area or that kind of area. And that's why the tests are particularly directed at that spot.
Yep. Right? And the reason for that is that you have a large viral load in the lungs, of course, because the lungs develop pneumonia-like conditions. So when there's coughing, you're going to get a lot more viral load from the throat, from the trachea and the lungs at the time, especially during early onset. So this is really important that we do that. So for the sampling, and we're going to bring this up right now. You can see the sampling here. We have a Cento swab that we developed. It was validated. We have large numbers of it that we're able to produce. This was actually done through a 3D printing that we were able to do. It is CE labeled. It's listed with the FDA as a Class 1 exempt device, and it is validated with our test. So this is an all-in-one process. Everything has been validated to this testing. The testing has been validated to the swab. So everything is cross-referenced and is ready. It performs very well.
What does CE mean? And what does Class 1 mean?
Class 1 is what they call a low-risk device. That's the same way as it is for the FDA as in the EU. You have a Class 1 device that they consider a low risk. That means that you are not putting it into the body as a venous puncture into the bloodstream or a catheter for chemotherapy. So those are the things that they consider very low risk to be harm to the patient. And that's really what they look at is what is the risk of harming the patient? And that is a very high, that's a high expectation. So in this case, both the test in the EU as well as the swab are Class 1 devices. And in the US, the swab is a Class 1 device with the testing under the EUA for the FDA.
Got it. And I'm told that the actual nasal swabs are more painful than the oral swabs. Is that the reason that you went?
Yeah, absolutely. The nasal swabs are very uncomfortable, especially in children, because you have to go all the way back to the back of the nose and almost down towards the back sinuses to get enough sample in order to get enough RNA extracted to measure the virus. And it's very uncomfortable, especially for children. They have very short noses, they have very small nasal passageways, and so it's very uncomfortable. Even for me, it would be very uncomfortable.
You did your grandchildren, right, recently?
I did my grandchildren as well as myself and my 2 children and their husband and wives. And my grandchildren would just say, "You're gagging me, you're gagging me, you're hurting me." And we were using the nasopharyngeal at the time. And then we used the swab for a second testing after they got out of school. And there was no problem. They kept their mouth open. They didn't have any issues with it. They were fine with it. If they wouldn't have seen grandma coming at them with a swab, they would not have known that I was doing it. They were very comfortable with it.
Okay, I think that answers our questions, and we'll keep going. So let's talk a little bit about the logistics and the process here. And Dan, do you want to take this?
Sure. Thanks, Sanjay, for the opportunity to speak with you and with your network. Excited about what we're going to do together to get things back to normal or normal-ish. So in the logistics and the processes, we are going to do consents at the point where we're going to be extracting the samples and a questionnaire for the test takers. The samples will then be
just to be clear, those consents and the questionnaire will be done by the school, not by Centogene or OESIS. But we will provide them with wording on those questionnaires that they would need to put in. Correct.
The samples will be collected by the schools, at the schools, and de-identified or pseudo-anonymized is the term we're using. The samples should all be collected in one place. We can talk through how that best works for each school. A nurse or an EMT is going to be extracting the swab, and the samples after extraction need to be kept in a cooler or a refrigerator between the temperatures of 36 and 46 degrees Fahrenheit. Most typical refrigerators are right around that temperature. Couriers will be arranged by our team to then pick up these samples at the location of the school and delivered to our labs. In that process, the samples will be kept in cooling packs to ensure that temperature of 36 to 46 degrees is maintained. So the turnaround time has been something that I've seen some questions come across here during the webinar. So this is typical turnaround time for labs, just like a LabCorp may send out a sample to you. And then that may take 24 hours, and then you send it back. That may take another 24 hours, and then 2 to 3 days later, the results will be available. That's the same as is the case with Centogene in this process. Results will be downloaded and provided to the schools. And those results will be tied to the de-identified number, which the school is going to maintain a record of who is actually associated with that number, what patients, or I should say what students or what faculty. And then they will provide the de-identification and provide the particular students with the results. And if there are any findings of positives, this will have to be disclosed to the CDC.
Dan, a few questions here. First,
Sure.
as I understand it, there are 3 results: positive, negative, or fail to get a sample. Correct?
Correct.
So that should provide a lot of information. And the word de-pseudo-anonymized is a bit of a new word for all of us, I think. But I think you can see here that there is a actual, let me see if I can get to it. there is an here it is, an actual number in those in that tube, right, in the glasses, and that's what will be correlated to what you have. So you don't have any information on the parents, who they are, or the students, or the faculty, whoever's being tested. It's only the school that has that information, and they have to work out from their numbers that they have. And this is for privacy reasons. I think this is really important to stress here, because privacy raises its head in a very, very big way. Let's keep going. Ellen, could you talk a little bit to accreditation and the reservation system? Because CLIA and CAP are not well understood by people outside of the system. What is CLIA? What is CAP? What does it take to get accredited? And what does complex lab mean?
For CLIA, we know that that's the Clinical Laboratories Improvement Amendment. It was written in 1988. That is the gold standard for the United States. In order to operate as a laboratory, you must have a CLIA number and you must be inspected by CLIA. CAP is the College of American Pathologists, and they have an agreement with CLIA because CLIA does not have enough personnel or funds to go out and do the inspections, that CAP will be a preferred provider of auditing of these laboratories for CLIA. So they have their own checklist that are combined with the CLIA guidelines, and in agreement with CLIA, they go out and they audit the laboratories. And we are in Boston, we were inspected by CAP and CLIA for our CLIA license, but we were also inspected by the Massachusetts CLIA board. Every state will have a CLIA board, and so we were inspected by those entities. In Germany, we had inspections by CAP and CLIA for all of our laboratories in Germany as well. Also in Germany, you don't have to be certified, but we chose to be certified by ISO 15189, which is an international standard that is recognized all over the world as a indicator for lab quality management systems. And we have gone through that. And also our biobank has been accredited by CAP as well for the standards that we maintain to maintain the integrity and privacy of all of our patient samples that we receive. For the testing, we are able to do 45,000 per week starting August the 1st. And we want you to reserve that time and a commitment to that, as we want to make sure that you get your results back as quickly as possible. So by reserving that time, we will put your schools into that queue so we know that the samples are coming, and we will put those into processing right away. So that's kind of our plan, is to have those reservations in order to make sure that we're meeting all of those turnaround times and get your results back as quickly as possible.
Perfect. So let me go to the next slide, which is privacy and data. So as we went through this partnership process, we had to make sure that the data issues and the privacy issues are really properly handled. So we will require, as part of this, that you get obviously the consents that govern HIPAA from your parents, faculty, and others. I think it's pretty clear from what people are saying that you have a right to ask faculty to be tested, but obviously you don't regarding everybody else. We also will probably need to put in some questionnaire language for under the emergency use authorization, particularly regarding congregate settings and other aspects. You will have responsibilities in the event that there is a positive to probably report to the CDC and local health authorities. We put in here GDPR because some schools have international students, and GDPR issues may arise. And then with employees, you probably have to look at any ADA issues. We are going to be doing a webinar on Friday with Fager Drinker on employee and student privacy and data issues, and we will send you details on that in due course. So here comes the important issue of price. What we try to do in this, and in particular, is try to bring down the price of the test. If you look at the price of tests that are in the market right now, most of the at-home tests you can only really do if you have symptoms. And there's a gatekeeping kind of questionnaire that usually goes. And if you've managed to get through that gatekeeping questionnaire, and congregate settings is one of those pieces, then you're going to be charged around $119 to $150 per test. Medicare Part B, which reimburses hospitals for high throughput tests, and there's a link here, you'll be able to get this presentation afterwards to that link, reimburses at the rate of $100. Now, health insurance is required if you have private health insurance to cover tests if you're showing symptoms, obviously, and you have a doctor's order. And so what we have tried to do is bring the test down. And so the price that is going to be offered by Centogene here is $88. And our estimate is that it's going to be around $10 for transportation per test. To add on top of that, that'll go down a little bit if there is more volume. That's for a typical school with 350 tests in one batch. So what's the process? And then we'll take some questions on this. What we have done is we have set up an application process, and I'm going to show you the application in a minute. That application requires you to agree that you understand certain elements of this process. There is a deposit of $5,000 to be essentially part of this program. That is a non-refundable deposit. It puts you into a priority list of your testing needs being met. Half that deposit is immediately sent to Centogene. We keep a half of it. It's obviously creditable against the orders that you make. If you're a member school of OESIS, you can use that $2,500 that we keep towards pathways and conference registrations, etc. If you're not, then you can't. We need that deposit because we had to build a pipeline and a reservation system to make sure that the capacity that's reserved here, which is significant, is not wasted and is not given to other people. The strategy here is essentially that you are probably going to decide whether you're going to be testing employees or students and employees. You're going to be deciding the timing, whether you're phasing various different elements or not. You're looking at the logistics. You'll be dispatched the swabs once your orders are confirmed. Then Centogene will organize the delivery logistics with couriers that they've been working with for many years. You're probably going to be surveying the parent body. And in the meantime, you're going to be looking at the impact this will have on your reopening. I think for many schools, if they go down this process, it'll give them a lot of comfort that if there is another outbreak, that's going to be able to be handled more easily, because they will have really good data on who has the virus. And it'll also give a lot of information regarding contact tracing and all those kinds of things. So with that, I'm just going to stop sharing here the screen, and I'm just going to show you very quickly the form. If you go to the partnership piece of our website, you will see a partnership announcement. And if you go to application for school participation, you will see a link. Go to that link, and inside that link, you will see this form. This form asks you for all your information. You can ask questions. It asks you for when your school is currently scheduled to start. You can ask questions, or you can show that you understand the process here. There's a lot of detail. And so use this form to either register and apply for your deposit, or to ask questions. We've done it this way so that the questions are related to particular areas, and we can process this because we think that many schools are going to be interested in this. And with that, I'm going to stop sharing and take some questions. And here we go. should we do both employees and students, parents? I think that's a decision for you. I'll answer that question. I know that employees obviously are very keen to find out whether or not they will be infected by this as much as students and parents. I have tested this with a number of schools, obviously, before we went down this path. And we think that there is significant student demand, parent demand for this. Who pays for this is the big issue. This is open to public or private schools. There is obviously private, there's public school money in the CARES Act, 13 billion allocated. Those allocations are coming in July. For independent schools, we believe that parents would be interested in paying for this because of the safety is one of the big reasons, obviously, that they send their students. So again, that's a strategic decision for you. Here's another one for you, Ellen. What does a positive result tell you about your state of infectiousness?
In this case, it would mean that you were actively you were infected. So that means the virus is alive and you need to go into quarantine right away. So for our test, as soon as you test positive, then you are infectious to everyone around you.
How long can you be infectious for?
7 to 10 days, or 7 to 14 days. It just depends on when we caught it in you. If you had no symptoms, you could have had it 3 days before, but they recommend that you stay home for 14 days.
Got it.
After you're diagnosed positive.
Why can't we just go and get a free test? Most of the tests require symptoms. If you go and get a test, you will be covered. So asking, I suppose, all your employees and students to go and get tests, and then asking them to share it with you would be a process that you could do, but obviously it's not going to be an organized process, but it certainly would be a process. This is a way for essentially an employer, a school, to test everyone at the same time and manage that process. Which is less painful? I think we've answered that already. Can the parent supervise the test in a car without a nurse and then just hand over the sample? Ellen?
Yeah, I think that's fine, as long as they have the instructions. I think that we could do that. I mean, we are doing that in other cases, but we need to make sure that they understand how to sample. And the instructions and the video are available for the schools to review, to know how to take the samples. But again, we need to make sure that they're able to take the sample properly.
Got it. I think you've answered this question, but Dan, this is an important question, so let's just be clear on this. How many days after the swabs are collected will we get the results?
48 to 72 hours, most of it 48 hours.
Got it. How often should we do these tests? Again, that's really a difficult question to answer. I know that some schools have said they would consider doing this every month, but that's a very expensive $100 per student. It's like $1,100 a year. How much does sensitivity drop if tests are batched? And can Centogene do that to save expense?
Well, we want them to be batched, and you don't lose sensitivity just because they're batched. We do that. They're done on a plate of 384 samples at one time. That's how they're processed. They go into a high throughput automation that's fully validated, and the plate contains 384 samples.
Got it. What happens if a student parent refuses to be tested? Can an employee refuse to be tested? I think a student parent or parent absolutely can refuse to be tested, because that's their right. So in those circumstances, if you have required your students to take a test, then I suppose they'll have to stay on the online program if you have an online only program, or else you might do something like get them to come in every day for 5 days and have their temperature checked, or for 14 days if they're potentially infectious for 14 days. But those are contractual issues, because presumably you would have signed a contract that didn't ask them to be tested, and you have a contract to keep them at school. Can an employee refuse to be tested? We will address that in the webinar on Friday, but I think the answer to that is no. What if we are doing a staggered schedule, one cohort at one time and another at another time? Can we split the testing? Yeah, I don't see why we can't, right?
Exactly, exactly, that's fine. You just schedule when you want to do the 2 cohorts and it's put on the schedule, it's fine.
When do cheaper antibody tests become more relevant?
Well, again, the antibody test is good only if you know the antibody tests are only good if you've been infected. And then you know if you have antibodies that will fight COVID virus. So you could keep running antibody tests and still not capture when you first become sick, because they're built in only to measure after you've been sick and after your blood has produced antibodies against the virus again for next year. So, I mean, the antibody test isn't going to give you any information at the very crucial time that you're sick right now. It just won't work.
Let's keep going. Is there any comparison data for your test compared to antigen detection?
Say that again. Sorry, Sanjeev.
Is there any comparison data for your test compared to antigen detection?
Well, again, it's 2 different things, so they're not going to be comparable. They're measuring 2 different entities. We're measuring viral load at the beginning of it, and the antigen and antibodies are being measured after there's been infection in the body. So they're 2 different entities that you're measuring. It doesn't make it, there is no comparability of it.
Got it. Okay, for children, would this be similar to a strep test? I think we've answered that.
Yeah.
Will the slide deck be available? Yes. Will our nursing staff be able to administer swab sample collection without a clear license or waiver? Yes. You don't need a clear license or waiver to administer the swab sample, right, Ellen?
Yep. Yep.
The school is responsible for collecting the sample. Yes. The school is responsible for notifying Department of Health in the event of a positive. Yes. Do you need a site clip waiver or other certification to obtain samples at a school? No. Do the nurses get the results of the test or just the family? Only one person at the school designated gets the results, and those results are pseudo-anonymized. So just a number. You're the only people who have the name of the person relating to that number, and you have to correlate it, decide then who you have to contact, and deal with the process thereafter. Are the numbers entered manually or are they scanned into an app? Dan, I think you talked about offering potentially a scanner for the pseudo-anonymized numbers, correct?
Correct. Yeah, that's correct.
That's possible. What is the frequency that this should be used with? That's up to you. $10 per test for transportation. Yes, $10 per test for transportation based on transportation to one of the labs of Centogene that's CLIA or CAP certified. It's an expensive process. We've done this. We will just do every single one on an individual basis and give you the estimate, etc. What about the incidence of people testing positive 5 to 8 weeks after recovery, finding those were inactive viral particles? New York City is testing anyone who wants one for free. Yeah, people are saying that they are testing for free. I heard that also about protesters in Chicago. I think in Illinois. Illinois has about 6,000 tests per day. That's pretty much equivalent to this whole 45,000. So the ability to test everyone is really not there. False negative percentage, I think we've answered that. Can an athletic trainer perform the test? Why does it have to be a nurse or EMT, Ellen?
Of course they can. They're trained also. But, you know, the nursing, anybody that would monitor the sick room, they can be easily trained to do that. So an athletic trainer, of course, that would be fine.
Can we test parents, siblings not at the school? Not at the school. So you'd have to get, no, I don't think that's going to be possible because you have to get consent forms for the people you're testing. And so why would you get a consent form for a sibling who's not at the school? I don't think you want to be doing that. You could get it for parents because they're part of your community, but siblings not at the school is a good question. You'd have to think carefully about that. Do you have a minimum or maximum amount of tests that can be sent in at one time? Well, the cost of sending a batch less than 350 takes the price per test of transportation above 10. But other than that, there is really no minimum or maximum amount of tests. Correct, Dan?
Correct. I would keep in mind we have only so much space reserved for your project, though. So we'd have to make sure that we get enough notice in advance of excessive amounts, if that makes sense.
Got it. People have tested positive with a PCR test weeks after their first test, but are not considered infectious. But you are saying that a positive result with your test, a person is still considered infectious.
Absolutely. That's a live viral that's being measured at very low levels. And yes, our test is designed for the early detection of the live virus.
Yeah, I think it's important for you to do your research on what kind of tests exist. Polymerase chain reaction tests, PCR, real-time, high throughput tests are considered to be the gold standard. And they have very low false positive rates, and basically they are the tests used by hospitals all around the country. I think that's it. I think I've been through all the things. Let me see if there's anyone who has raised a hand. Yes, we have one attendee, David Nichols. I'm going to let David talk. David, are you there?
Hi there. Yes, can you hear me?
Yes. Where are you from, David?
We're based over in Boston. We're actually a diagnostics consulting group that's advising several schools. And so we're potentially, some of them have asked about this webinar, and we're on here to learn a little bit more and see if we want to advise them. So one of the questions that a lot of our clients have asked is if Centogene, and I know this came up a little bit earlier, but wasn't necessarily answered, are you able to run testing on pooled specimens? So we've seen other testing laboratories take 100 specimens, pool them together.
No.
You're not able to. Okay.
No.
Well,
that's not something we would do.
Well, actually, Ellen, I did talk to your CEO about this, and he said not initially, because the sensitivity drops from by about 5 percentage points for every additional person handled. And you have to establish a base case for that. I think the answer is probably not initially, but maybe down the road. And
yeah. And the reason, just to clarify, is we're working with some institutions that are rather large. And so it's not feasible for them to test on the regularity at which they plan to test. They would run out of capacity of what you're offering. And so we're trying to find ways to achieve some efficiency there.
Oh, I see what you're saying.
We're not really interested in doing huge populations. We want to have as many schools have access to this inventory because it's not that much. If you follow me, David?
Understood. Yes. And
I mean, we don't want someone taking 8,000 or 10,000 of this inventory from one source.
Exactly.
Okay, got it. We have Steve Schindler. Stephen, are you there? Steve? Okay, we'll take one more. Brad. Okay, Brad. Brad, are you there? Brad Sakuda?
I am here. Hi, and I'm sorry, and I had to come on a bit late. Just confirming, this is the oral swab, not nasal.
Correct.
And I've got a preschool young population. Is this a test that's it's reasonable to expect a parent to have a young one take.
Yes, definitely. It's much better for them doing it orally than it is nasally. So it's something that can be done much better in young children using our swab.
Hey, Brad, obviously know you guys. I think just to be clear, what we're trying to do is to have everyone tested at one time in one place so that we can have the swabs collected immediately and not have, a missed logistics situation take place. So we don't really want this to take place at home. We want this to take place in or near a school or at the school.
Yeah, I got it. Like a drive-through day.
Kind of like that. Or, some schools are looking to do some schedules that rotate. And so you might have some kids on campus for 4 days or 5 days, like a 10-4 schedule, things like that. And you may decide to test the whole population at the end of it. Or you may decide to test the population before they come back, et cetera. Or you may decide, look, we desperately need our elementary school population to be back in school first. We're going to do all the elementary school people first, manage it that way. There are so many different ways that you can think about this.
Thank you.
All right, Brad. Now, Brian, are you there?
Yeah, can you hear me?
Yes. Hi, Brian. Where are you from?
First of all, thanks to the person that asked the pooled testing question. That was one of mine. The other was about HIPAA compliance. Maybe this is for the subsequent call, but does the school need to become HIPAA certified? And are there IT requirements that HIPAA imposes on how the pseudo-anonymized coding is handled?
There will be HIPAA requirements for us to give it to you because we're not giving it to parents. But you are going to be giving it to parents, so you're definitely going to be within the HIPAA guidelines. I'm not a HIPAA expert. These guys who will be on a HIPAA experts, but you'll have to get your own. We will give you wording that protects Centogene regarding HIPAA and GDRP regarding your responsibilities. But other than that, I can't really talk as a lawyer. Dan, do you want to add anything to that?
No, I think you have a webinar coming up right on Friday.
Yeah.
That
Sorry,
might be
I can't really add any more to that, but does that?
Yeah, thank you.
All right, good. And we have Glenn. Glenn, are you there?
I am, yes. I was curious to find out, do you have any geographic limitations as to your ability to get to labs?
Yes, nothing outside the United States.
Okay, but in the United States, completely fine. Anywhere.
Well, yeah, anywhere. But look, you guys, Dan, you can speak to this because you've dealt with all these logistics providers, right?
Right.
What's your answer?
Yeah, no, absolutely. We can reach you if you can be reached. We can get to you. We have a bunch of different couriers we've partnered with, and the goal would be to learn early in the process as possible who's interested, how many participants, and then we'll arrange for a courier and give a date that you can do the draw that's most financially acceptable, if that makes sense. And they'll come and pick it up and put it on a cold pack and be on its way.
So I guess one of my follow-up questions would be, if you have 45,000 tests you can do a day, how many of those tests?
No, a week. A week.
Okay, so how many are allocated per institution? And we're talking about 350 as a sample number to send in. But if we're a smaller school and we suspect maybe 10 students need to be tested, how does the pricing?
It's not going to work. It's not going to work at that level, Glenn. The transportation costs, etc. It's probably not going to work. You're better off going to one of the internet providers like LabCorp, getting them to send you a test sample, sending it back. It's 48 hours. Getting the sample back, paying 120 bucks, yeah, I think that
was helpful. Thank you.
All right, great. Liz, are you there? Liz Ann?
I'm here.
Okay.
what is the frequency that you're recommending that this be done? And you are recommending you do entire cohorts, like the entire lower school or something like that?
We're not recommending anything in terms of how many times you do it or who you do it for. I think that's really a question for you. I'm sorry. Can't be making that decision for you, unfortunately. Alison?
Yes, hi. Well, you kind of answered my question already. I just wanted to confirm. So any of, well, we have 2 school nurses. So either of us, we could select an EMT from nearby, or you said the athletic trainer, correct? Could be the parties that would be collecting the samples and are performing the testing, correct?
Yes. Yes.
Okay. Yeah, you answered my question. Thank you so much. I just want to.
You're welcome.
Teresa, are you there? Teresa Smith?
I'm here. Can you hear me?
Yes, hi, how are you?
Hi. I was wondering if you could tell us where we could read like a third-party assessment of the reliability of the test, right? You're saying it's 99.9% reliable. Where would we validate that?
You can go to our website and we have all of that information published.
Okay, thank you.
You're welcome.
Megan? You there?
Yeah. Yes, thank you. I have another question regarding minimums, et cetera. We are a small school. If you were to send a sample or samples, what is the minimum that would be effectively financially acceptable? If we were to send 125, would that make it reasonable, or is that too low at each batch?
Dan?
It's hard to say without exact locations of the schools, but I can work with you on that. Furthermore, even the time that you set the pickup dictates the cost. So it's certainly going to be more than $10, but how much more, I don't know. But I'm happy to work that through with you.
Okay, thank you. I appreciate it.
Sure.
Oh gosh, it's just going crazy. We'll just take a few more questions here and see who there is. Eve Fraser, Eve Fraser, are you there? Hi, Eve.
Hi. So I was just wondering in that vein, so if we do swabs and we're trying to get up to about the 350 mark of collection, how long can they sit in our, we have a vaccine fridge so we can have it at the right temperature. How long can they stay before the courier picks them up? Like if it took us a couple days to get the sample size that we wanted to send you all.
I don't think that's going to work because the sample has a 72-hour shelf life. And so that's not going to work.
Okay, thank you.
Yeah. Okay, I think we're going to call it a wrap. Thank you very much for joining, everybody. Thanks, Ellen. Thanks, Dan. You'll receive a copy of the slides on this webinar, and you can always contact us for further information. Appreciate it.
Thank you.
Everybody. Bye-bye.
Thanks.
Thank you.